Sorry for the delay, everyone. I'm Rachel Choron. I'm one of the trauma surgeons here in New Brunswick. And I just wanted to start by saying thank you to the New Jersey Gun Violence Research Center for the opportunity to do work within our hospital institution here at Robert Wood Johnson. Next slide. So just to my disclosures are that I'm funded by this organization, and this is the title of our project here. Next slide. We'll go pretty quickly through the first portion of the presentation, just highlighting how relevant firearm violence is and how it's an American public health crisis. There's a severity and disparity of homicide in this country as related to gun violence that's been increasing over the past decade. And although we're a leader in the United States in many arenas, we're falling behind when it comes to firearm injury prevention. The rate of violence, suicides, and unintentional injuries in the United States is highest among industrialized countries. And specifically, it's even 25 times higher. And the suicide rate is 8 times higher than other developed nations, which you can see in these two figures. And this really affects a spectrum of ages and socioeconomic groups here in our country. Next slide. So this is a figure that just indicates firearm ownership across our country. There's 400 million firearms owned privately by civilians, which puts us first among all nations when comparing the number of privately owned firearms to other countries. And it's been shown that having a firearm in the home increases the likelihood of homicide, suicide, and other unintentional injury. Next slide. So in the US, more than 5 people die every hour, 1 every 11.7 minutes, 123 a day, and 45,000 a year from gun violence. Next slide. So when looking at deaths secondary to firearms, these numbers are highest that they've been in 40 years. And not only does America continue to face an extraordinary mortality nationwide secondary to firearm violence, it's increasing. Next slide. So you can see that there was 44,000 deaths in the past year secondary to firearm violence. And next slide. If you compare that to 2014, that number in 2014 was just over 12,000. So you can see how dramatically increased it's been in the past decade. Next slide. And so when looking at the trends over time with regard to homicide and suicide, the firearm suicide rate has been consistent and steadily increasing, with only a few exceptions. And the gun suicide rate has increased 25% from 2006 to 2020. Next slide. So the greatest burden of homicide is seen mostly in our predominantly young men and specifically Black and Hispanic communities. Young Black males from 15 to 34 are especially disproportionately impacted, making up 2% of the population, but they account for 38% of all gun homicide fatalities. The overall firearm mortality between 15 and 34 is 5 times higher in the Black community than in the Hispanic community and 21 times higher than in the white community for the same age distribution. Next slide. So historically, the number of deaths from motor vehicle collisions was always higher than deaths from firearm violence. However, this has recently changed. And the number of gun deaths and motor vehicle deaths are now similar, and gun deaths have now even overtaken motor vehicle deaths. And this just really emphasizes the high severity injury and that's associated with firearm mortality here. Next slide. And sadly, this is not specific to adults. So in 2019, firearm injury surpassed motor vehicles to become the #1 cause of death in children 0 to 19 years old. And the increase in firearm injury death has been attributed to an increase in time secondary to homicide and suicide. Next slide. And so when you analyze the intent of firearm death by age group, the unintentional injury represents a large proportion of deaths between 0 to 4. And the proportion decreased as they get older, with at least 1/3 of firearm deaths being suicide in 10 to 14 and 15 to 19 years age. The homicide injury is the most prevalent across all ages. Next slide. So here is a look at firearm related mortality by state. New Jersey is actually the 47th ranked state. So that's important to note when we're looking at everything. Next slide. And like a lot of other states, New Jersey has suffered a pandemic within a pandemic. Throughout New Jersey, the number of shooting victims rose by 8% in 2020, and then again in 2021. In 2020, 218 people were killed, which was 24% higher than 2018 and 45% higher than 2019. Next slide. So our center, Robert Wood Johnson in New Brunswick, is one of the academic medical centers for the Robert Wood Johnson Barnabas Health System. We have 3 New Jersey level 1 trauma centers in the state, us being one of them. And we've experienced higher trauma volumes throughout this COVID pandemic. In early 2020, we had nearly an 185% increase in penetrating injuries presenting to RWJUH and a 214% increase in GSWs. 59% of those patients were Black and 7% and 11% Hispanic. Next slide. So in addition to this burden of disease on our population, there's also a huge substantial economic burden of more than $280 billion per year to the United States healthcare system. Next slide. So while firearm mortality burden is staggering, there are so many more people injured than killed every year, with 3 out of 5 non-fatal gun injuries affecting those out of 30 years of age or younger. And so this is really the group of non-fatally injured survivors that we can affect change in. Next slide. So we can do better. There's really opportunity here. Next slide. Dr. Bonnie in Newark is really one of the leading researchers in this field. And she looked back over 17 years of GSW patients in Newark and was able to identify hospital violence intervention programs can decrease recidivism. They looked at just about 10,000 patients and identified about 8,200 were at risk for recidivism, and 6.2% of those came back to the hospital having been shot a second time or more. And that graph in the upper right-hand corner, you can see with each subsequent hospitalization for being shot, their mortality went up. So a little bit over 10% risk of dying with the first GSW, and then thereafter, nearly 50% mortality for the 4th incident. Next slide. So, we've identified this problem and we've identified the population we need to target. So how do we affect change? And HVIPs, hospital violence intervention programs, are one pillar in the public health community that we can combat violence, recurrence, and provide resources to our survivors. Next slide. So how do HVIPs work? Firstly, it starts with intervention, and this begins with a brief intervention in the emergency department, at the bedside, while in the hospital. And then care is the next step, and this is followed by intensive long-term community-based case management service in months following the injury. And then there's links provided for follow-up service, crisis intervention, linkage to community-based services, mentoring, home visits, follow-up assistance, long-term management. And then HVIPs also address social determinants of health. They elevate issues of the revolving door of violence while addressing equity and building partnerships with communities and survivors of violence. Next slide. So firstly, there's a public health approach to this violence prevention, and it's acknowledging that there's modifiable risk factors associated with violent injury. And these are including education, lack of job opportunities, injury, criminal recidivism, socioeconomically deprived neighborhoods, substance abuse, PTSD, things like this. Next slide. And then the next thing to identify is that there's a teachable moment. After being shot, this is a real opportunity for change. And it's also an opportunity to limit retaliation and recidivism in this moment. So using this teachable moment, culturally competent case managers and trauma-informed care helps provide movement forward from this situation. And ultimately, our case managers are credible messengers, ideally coming from the community and understanding urban violence. Next slide. So typically, the case managers develop a rapport with the victims and begin identifying and addressing their individual needs. Many of these high-risk individuals have suffered violent injuries and are extremely distrustful of our mainstream institutions, like our healthcare and criminal justice system. So using a trauma-informed approach, violence prevention professionals can also often break through this distrust and help. Once gaining this trust, introducing the program, these violence prevention professionals can work with clients and their families to plan for their discharge from the hospital, and then figure out what immediate safety needs they have and provide services and establish goals. Next slide. So case managers really shepherd the clients through risk reduction resources grounded in strong community and city ties, and use a working knowledge of the landscape to provide these options. Next slide. So to give you an idea of how our HVIP connects our victims of violence to risk reduction resources, WAVE was set up, Working Together Against Violence to Empower. And this is a community consortium comprised of 25 service providers and organizations that the RWJ HVIP works with to connect our patient population to services. Next slide. So this is a list of all the different community agencies on the left and other agencies on the right that the HVIP partners with. And representatives from each of these organizations have regularly based meetings with our HVIP to help connect clients to services. And you can imagine, if you leave the hospital without being connected to HVIP, how do you find these services? How do you find these community organizations on your own? Next slide. So what makes up an ideal comprehensive HVIP? So you need enough case managers, you need sustainable funding, in-house mental health services, long-term follow-up, being able to really use that teachable moment in the community setting, and then being able to qualitatively and quantitatively analyze the outcomes of the HVIP, and then have formal partnerships with the community in the city. So this is our RWJ HVIP. These guys are absolutely incredible. Miriam Mercade, Elaine Hewins, Lauren Binder, Jesse Cordova, and Ariel Jimenez. This is our HVIP here in New Brunswick. And I've had the privilege of getting to know them a little bit and work with them through this process, and have really been overwhelmingly impressed with their dedication to the patients and leading the charge to improve outcomes here. Next slide. Oh, I'm sorry. That's go back one slide. Oh yeah. Okay. Go up ahead one slide. So how do we support all these independent HVIPs across the country? So there's something called the HAV, Alliance for Violence Intervention. And this is a national support group that kind of helps manage on a national level. And they provide different resources to help get programs started, an annual conference, some data sharing, a national data bank, and working groups. And so the idea is that violence is preventable, and that is the strategy to move forward. Next slide. The American College of Surgeons Committee on Trauma, ACS-COT, also is another national governing body that has created a primer to help facilitate providers through the process of creating an HVIP at their own center or institution. And so this is a list from the ACS-COT of what essential elements are needed and how to start advocating on a hospital level to create an HVIP. Next slide. So these are some of the things that you want to evaluate and keep in mind when an HVIP is set up. Next slide. So there's been some notable programs that have been set up in the mid-2000s, and there's early data on those outcomes from these centers. So San Francisco is one of the first centers that set up an HVIP. Next slide. And same in Richmond, Virginia. And both of these programs and studies found a decreased risk of recidivism. So this one found 15% prior to HVIP creation to 3.6%, and decreased ED resource utilization. Next slide. So these are some of the notable programs that have replicated and expanded in the last 10 years or so. Next slide. So even after all these notable programs really put out independent single center studies, one of the main trauma societies, East, really come up with guidelines based on hospital violence intervention programs because of a lack of data. So there's still a call to arms to try and find out and evaluate our HVIPs. Next slide. So there was a survey across 28 existing HVIPs, which there's about 50 right now in the country, to try and determine demographics across the population, who's using HVIPs, things like that. Next slide. And it also is looking at what are the barriers to starting and sustaining HVIPs. And pretty much the number one thing that was identified was funding. Typically, if they required 300,000 or more, this was likely to be federal or state or city funded, whereas the lower funded programs were typically found to be funded by foundations or philanthropy. Next slide. And so now this demarcates which states provide federal funding for hospital violence intervention programs. So you can see New Jersey is one of those states. And with the $1.9 trillion pandemic relief bill, part of those funds were allocated to violence prevention dollars, which equated to hospital violence intervention programs that were able to be started. Next slide. So Governor Murphy had announced in 2020 that 9 hospitals in New Jersey would be grant recipients to start HVIP. So we were lucky to be one of those 9. And you can see the New Jersey cities with the most homicides pretty much correlated with those 9 HVIP centers as well. Next slide. So this is demonstrating that we were one of the centers that was able to be funded by the Victims of Crime Act. That's where this funding comes from to implement our program. Next slide. And there's already been data that's been published showing that HVIPs actually save hospital systems money. Prevention of 3.5 injury recidivists per year render program costs essentially neutral. And overall, it saves a hospital an estimated $500,000 per year when recidivists are considered against the cost of the program. Next slide. So the reason this is important is because there's still barriers to funding and continuing our program. Additionally, the VOCA funds do not allow for any systematic evaluation of our program, which is why the Gun Violence Research Center has been so helpful in helping to fund our program to evaluate it. Next slide. So our aims were to assess the early impact of our HVIP on trauma patients impacted by gun violence. And we did this by separating the patients into 2 cohorts. One cohort being the patients that were shot prior to HVIP creation and those shot after HVIP creation. And we surveyed those 2 populations based on their socioeconomic outcomes and needs. And then also we used a validated study tool to determine long-term patient-reported outcomes, like how do they think they're doing after having been shot and gone through this experience. Our second aim was to figure out patients who declined or were lost to follow-up by our HVIP. What were some of the barriers there to utilization? And then also we want to create a framework and a data set to be able to self-evaluate our HVIP moving forward. So our hypothesis on the next slide is trauma patients who experienced gun violence and worked with our HVIP here had better socioeconomic outcomes and patient-reported outcomes as compared to those who did not. Next slide. So we performed a retrospective observational single-center study. We included patients 15 years of age and older who presented between 2017 to this month, essentially. And we excluded patients from the survey portion of the data set who are deceased. Next slide. So we performed a retrospective chart review of each patient's hospitalization, and then also a 30-minute questionnaire, which we compensated participants for. And we asked questions pertaining to socioeconomic outcome and then patient-reported outcomes using this validated NIH study tool. And then we used REDCap data system to log all of our data. So we're still in the middle of data collection. We've completed about 225 chart reviews of patients that have been shot in this time period. And we have completed 31 surveys of patients who have either used or not used the HVIP program. Next slide. So since we're still collecting data, we don't have final statistics back for the eventual manuscript and publication we plan on pursuing. But this is just an early look at what population of data we have now. So this is based on the chart reviews, which is complete, of our 225 patients. So who are our patients in New Brunswick? So you can see they're almost entirely male. Many are Black, disproportionately so. There's a good subset of Hispanic patients. You can see in the upper right-hand corner, that's a graph of age, which most are between 20 to 30. And we were really dealing with patients that were victims of assault, opposed to suicide. Next slide. And our mortality for patients who reached the hospital was 16.2% of patients who were shot died, and a 10% readmission rate. So it definitely seems like there's opportunity here for HVIP to help with that readmission rate potentially. Next slide. And then what I found really interesting was our recidivism rate when you look at the chart review based on our electronic medical record was 4.4% based on the 225 patients overall. But when we actually surveyed the first 31 patients, the recidivism rate for having been shot before was 12.9%. So maybe we just happened to hit on the 31 patients who had been shot before, but I think more likely the recidivism rate is much higher than realized based on hospital available data. And then when asking patients that we surveyed, have you or your family or friends been shot? Over 50% had a family member or friend that had been shot. Next slide. So what are the needs in this population? So we asked all these patients, what did they need? And so you can see over 50% needed help with housing after they left the hospital. You can see about a third needed help with employment and job situation in that left lower graph. And then there's victims of crime compensation that you can get and apply for funds after being shot. And so you can see that the majority of patients did not get that compensation. And then 75% of patients needed disability compensation or money after being shot. So these are the needs that the HVIP can address. And this is in our personal patient population that we surveyed. Next slide. So I think something that really also stands out is mental health in this population. So we asked patients, did you want or need counseling before being shot to help with mental health? And 58% said yes. This is before being shot. And then did you struggle with depression, anxiety, PTSD, or other mental health issues after being shot? And that was 86%. So 86% of people are asking for mental health connections and services. Next slide. So where do we go from here? So ultimately, the risk of recurrent violence can be diminished by HVIPs when influences such as social determinants of health are mitigated. And while there's been some single center studies that have reported decreased rates of recidivism secondary to HVIPs, there's still an overall lack of literature surrounding HVIPs and their impact. And that's something we want to build on. And really the time is now to advocate for HVIPs and support them financially to demonstrate their success through a collaborative, centralized approach. Next slide. So again, I just want to thank our HVIP members for doing the real work here. Next slide. And these are all my partners at Robert Wood Johnson. This is our trauma surgery team that I want to thank for being able to do this research. And then the next slide. And this is our team of HVIP researchers, those middle four medical students that have been completing the surveys and chart reviews, and they've been doing an outstanding job. And next slide. And then, of course, I've got to show you a picture of my kids, and I'll end here and ask for any questions.
Okay, Rachel, thank you so much for that great presentation.
Thanks so much. I'm going to leave my email in the chat in case anyone wants to reach out.
Okay. If anyone have any questions, due to time, please email Rachel with any questions. Thank you so much.
Thank you.
It was a pleasure having you with us today.